Good morning. Thank you, Dr. Abhiday. Thanks for the kind words. Thanks to Professor Jindal, Dr. Jaideep, and the team Bhopal for the invitation extended. The only good thing I shall say that this is the blessing given to me is I am discussing not so rare form of diabetes in the rare forms of diabetes. So, I mean, I am blessed in that because I'm sure most of you would have encountered very many number of cases of pancreatic diabetes. You just have heard the last discussion after Sachin's talk. It is like, it presents in many forms. So that is what I am going to discuss. The diabetes of the exocrine pancreas, and I shall discuss under the following headings, the semantics of which are more important, which I shall be covering, some issues about pathophysiology and what are the unique features of this, and a couple of slides about FCPD and some of our data in this, and finally I'll conclude in about 15 to 18 minutes. To start with, I'll show one of the cases which actually surprised us earlier days. 13-year-old male who is a known case of vitiligo for 3 years, presented with osmotic symptoms of 2 months, and height and weight generally on the lower centiles, prepubertal, dystrophic nails, and RBS was 455. A common garden presentation of a type 1. So I was 100% sure this was type 1, nothing else, because there was vitiligo staring at me. This you can see, it is something known as a acrofacial variant of the vitiligo, and you can see the dystrophic nails here. So I was sure that this guy with osmotic symptoms and RBS of 455, this can't be anything but type 1. So when we checked for plasma, urine ketones were negative, reconfirmed by plasma, both were negative. That is where actually things started not falling into the place as what I anticipated. And when you actually get something like this, you look beyond and look close by as to what are the other etiologies. And when we looked at the other issues, the A1C was raised, GAD was negative, even though his antibody thyroid was positive, thyroid profile was normal. Ultrasound picked up a doubtful cystic lesion, but they couldn't localize the origin of the cyst. So that is where it led to us for a CT scan. X-ray showed no calculi, and this was a CT scan which shows atrophic pancreas and a nicely pancreatic cyst formation, and with some collaterals because of associated splenic vein thrombosis, a long-standing pancreatitis with diabetes in a 13-year-old boy without any calcification. This we published in Journal of Pediatric Endo long back. So diabetes in young unusual because he had all the features of type 1 APS, being ectodermal dystrophy, vitiligo. There were no other features. But when you looked at, actually it was not type 1, it was a diabetes due to a diseases of exocrine pancreas. So then we looked at other things, and then I'll cover the next topic. The DEP, as commonly known, is known for long duration, but unfortunately is neglected. Whenever you see the standards of medical care published annually, there are only few paragraphs about the DEP, actually speaking. But that is the second commonest type of diabetes in adults, even next only to the type 2. So it requires some more interest, some more data, some more focus on it. Why it didn't have this is only because of the confusing terminology, because we don't actually know how to classify somebody either pancreatic diabetes or diabetes because of a pancreatic dysfunction. So that confusion led to people neglecting it. So you have different subtypes, even in, acute pancreatitis, chronic pancreatitis, and some of the others said you require to have an exocrine dysfunction. Some said, no, you don't require exocrine dysfunction. The complications are more, there's difference in the mortality. So there is a lot of issues concerning this. So possibly the lack of uniformity in data collection, lack of proper definition, and this led to a, lack of proper research in this. So that is what is possibly led to some of these receiving less focus than type 2. This was our data about incidence of chronic pancreatitis. The DEP per se, the incident data is about 3 to 10 per lakh population year follow-up. Our data showed almost about 7.5. You have multiple etiologies for chronic pancreatitis. I will not go into that. I will just restrict into the diabetes of the exocrine pancreas. Even before insulin was discovered that it is from the beta cells and pancreas, 1892, the term pancreatic diabetes was coined because the moment you remove the pancreas, you develop diabetes. This was before identification of insulin. So there was a link with the pancreas established before insulin. Later on, when they identified something like a typical exocrine dysfunction, the term pancreatogenous steatoria came into place because your pancreas is not working, exocrine dysfunction, and you have a fatty stool. So this term was maybe continued in the 50s and 60s about as a term pancreatogenous diabetes or pancreatoprivate diabetes. And then came this, which has actually rather confused the picture. This was a group of neuroscientists who were working on actually the Alzheimer's disease, and they found that there is plaque deposition and there is more of IGF resistance, insulin resistance there, which they said that in the Alzheimer's, because by that time the terminology changed from NIDDM and IDDM to type 1 and type 2. So they said it is a insulin resistance specific to the brain. So is this type 3 diabetes? This was the first paper published in 2005, late 2005, which coined that type 3 diabetes. That was only restricted to neurologists and nothing beyond. But a group of interns from Germany, actually who were assigned their PhD thesis in the pancreas, put hold of this paper and caught hold of the ADA classification. The ADA classified diabetes in using the Arabic numerals 1, 2, and the Roman numerals 1, 2, and 3, and gave the C as the diseases of the exocrine pancreas. So this group has said that now we are doing a research on type 3C diabetes using the Arabic numerals. And then later on, this continued that many others used type 3C diabetes like a diabetes due to pancreatic diabetes, despite no official publication by the ADA or WHO classification that you use this. Many of the ADA standards of medical care just mentions that it is type 3, commonly known as, but no group has ever given this terminology. It is originated from a group of medical students, actually speaking. The Cosmos group is the one led by Petro from New Zealand, that who has extensive data about the pancreas and their disorders. And they gave the term what is known as the diabetes of the exocrine pancreas. And then this was to just make it universally same and have everybody on the same platform, and then classified them. So possibly this is what is being followed in the near future in the last couple of years now. This was a paper published about few months back in the European Journal of Endocrinology. Thanks to Jindal sir for sending me this. The new classification of DEP is actually it is known as post-pancreatitis diabetes mellitus. Either it is on the acute or chronic, depending on what pancreatitis. Either pancreatic cancer-related diabetes or cystic fibrosis-related diabetes. These are the only terms which are used in the DEP. You should exclude whole host of factors whenever the pancreatitis is present. That is important. That is described in this. Let us presume somebody is admitted with a first attack of pancreatitis. This is on the x-axis, and the y-axis is a time frame. Now, at the admission, if he was already a known case of diabetes, he is already on tablet or something, he is just diagnosed as antecedent diabetes mellitus in pancreatitis, because you are already a known patient of diabetes. Somebody is admitted with pancreatitis, you don't know the parameters at this time, and you have detected to have the diabetes and then followed up later. This is pure post-pancreatitis diabetes mellitus, be it or acute chronic. The other entity, you are admitted with pancreatitis, you have diagnosed parameters of A1C less than 6.5. There may be stress hyperglycemia, that is not an issue. But if your A1C is less than 6.5 and during follow-up you have developed diabetes, this is known as new onset diabetes after pancreatitis. So it is like now based on the relation between the attack of pancreatitis and the time frame and the investigations, you should be able to classify the patient properly and then follow up them. that will give you a possible issue, possible good information about how best to deal with the patient. The importance being during acute pancreatitis, as I said, there is at least 10 to 20% of patients have transient hyperglycemia, and some of them will have progressed to develop diabetes permanently due to the inflammation, scarring, and fibrosis. There are differences in the pathophysiology between the acute pancreatitis and chronic pancreatitis. That is important to know, because 22% of patients with acute pancreatitis have recurrent acute pancreatitis, and about 1/3 of them develop chronic pancreatitis. The only important difference, the insulin resistance is the key factor in the pathogenesis of diabetes in the acute attack of acute pancreatitis, first attack. Whereas in the end stage chronic pancreatitis, it is only the loss of beta cell function which is there, which is the predominant pathophysiological mechanism. So the importance in this progression, in this journey, you may have a spectrum of features of exocrine and pancreatic volume, that atrophy and all gradually happens. So you may have overlapping features in between. But why I'm highlighting this is, in the acute pancreatitis, possibly the metformin or insulin sensitizer has a major role, and in a chronic pancreatitis, it is more of a insulin which is useful rather than a insulin. And to differentiate some of the key markers, oxyntomodulin is coming up as a big way, which will help to identify, low levels obviously indicate that it's a pancreatitis one, especially when you have to differentiate between a older, pre-existing diabetes, or is it due to a pancreatitis per se. So that is where it is important to identify the pathophysiology and see the progression. And earlier days, it was only considered as the acute attack happened and thereafter patient recovered, nothing is going to go wrong, which is not the case. The recent studies have shown that there is going to be a continuous low-grade inflammation in the pancreas also. So almost 1/5 of patients have the recurrent acute pancreatitis. Now, when patient develops pancreatitis, what are the risk factors for him to develop the post-pancreatitis diabetes mellitus? The males obviously are more risk than when compared with females, which is not seen in the pancreatic cancer-related diabetes. Some of the patients, the younger ones, are at more risk. The middle age, there is equal, and it is in the older age, possibly it is more harboring onto the type 2 spectrum. So young and relatively less than 40 is the more risk factor to develop. And there are some studies which have said even I'll show our data also in that some of the visceral adipose tissue, the pancreatic fat, all those things which forms the body composition have an impact on who develops the post-pancreatitis diabetes mellitus. Recurrent attacks, obviously you have got more damage to the pancreas, so that is why you're having more risk. And somebody who has atrophic tail, almost always 90% have the risk of having diabetes. Exocrine disease is not a mandatory, but presence of exocrine dysfunction definitely will increase the risk of your diabetes. That is why some of the studies from Dr. Mohan's group from Chennai would show that maybe in acute pancreatitis, you should give pancreatic enzyme, which will help in preventing the diabetes. So there is some data to suggest that maybe it is useful in preventing. So if there is any coexisting exocrine dysfunction, you are at a higher risk of developing diabetes. The only other myth which is there is a severe acute pancreatitis has a higher risk than when compared with mild, which is not so. The mild pancreatitis attack has got equal risk irrespective of the severity of the first episode. Etiology also, there was not much of difference between the alcoholic versus the stone disease. So there is not much of difference. Now coming to DEP, what are the clinical issues? I'm sure most of you would have been troubled by umpteen number of patients about the brittle diabetes in these patients. You give some insulin, they go into hypo, you just down titrate, they will come with possibly very poor control. They don't come with ketosis, but they'll always trouble you that, Dr. Saab, my sugar is always at 400 or 500, how best to control? They are ketosis resistant. because of small amount of insulin and absent glucagon and other factors. Poor control is one of the characteristic feature of this type. Because of the brittle nature, there's a lot of variability, and you don't get a good A1Cs in pancreatic diabetes, and they're glucagon deficient, which will have an impact on how best you look at their hypoglycemia management. This was data from, again, Cosmos group, which showed that what are the outcomes as far as the mortality in comparison of type 2 versus post-pancreatitis. The cardiovascular remains the same, but you see the second subset, the cancer-related mortality goes markedly high in the post-pancreatitis diabetes and gastrointestinal disorders and infections. So the cancer-related, predominantly the pancreatic cancer and GI cancer mortality is more in this group. So that is what is a cause of worry in these patients. Going on to more relevant or a subset which is closer to us is the FCPD. Phenomenal amount of work done by Dr. Mohan's group. The TCP, that is tropical chronic pancreatitis, when it develops diabetes, is known as the fibrocalculous pancreatic disease. The only good part is that there is reducing incidence in the last couple of decades. We unfortunately couldn't actually lay a hand on what causes this. I mean, cassava was the initial trigger because of identifying in the southern parts of India, but you get more number of data or more number of patients in people who don't even look at cassava. So then they looked at genetics, then looked at oxidative damage, environmental factors, but long and short of it, there is not one etiology which has been led, but this is a unique form of diabetes with a characteristic triad of abdominal pain recurrent, afterwards steatorrhea, and end stage being diabetes. In one of the first patients whom I had shown initially, he just had diabetes, possibly steatorrhea, which was not picked up. He was reasonably malnourished, but he never had abdominal pain. So may not have the typical classical features always. So you should keep the, clinical signs open. You should keep the differentials open in especially younger patients. DD obviously is the alcoholic pancreatitis, and some of the features to differentiate between alcoholic and TCP are there. It's alcoholic, obviously males are more commonly affected. The types of calculi are large and larger ducts in the TCP, whereas alcoholic you have a smaller ducts. And here the ductal dilatation is more common, and you have a very high risk of pancreatic cancer in TCP. Management, OAD in some and majority require insulin. This is the spectrum of FCPD, what we generally see. Most of about 90-95% of them are ketosis resistant, where a very minimal subset only requires diet. Some may require OHA, and majority requires insulin. 10% of them are ketosis prone, where you require to be more vigilant and more attentive about their insulins and more about their hypoglycemias. And why they don't get ketosis is because of the partial preservation of the insulin and alpha cell deficiency, which is one of the important factors, carnitine deficiency, and obviously they are at a low adipose mass, so you don't get so much of fatty acids to get breakdown. I'll last couple of slides about our studies. We had a cohort of close to 100 patients of chronic pancreatitis, out of which about 67 were alcoholic and 35 were TCPs. Male were 87 and 54 had diabetes, the so-called DEP. And we did extensive biochemistry on them, including all the bone markers. We did DEXA scan, including the composition scan, bone density, as well as for the body composition to look at visceral fat and HOMA-IR and other parameters. And what it was actually a PG thesis of one of our residents. First one was about looking at metabolic syndrome in CCP. About 27 patients had metabolic syndrome characteristics, and we looked at how many had actually insulin resistance using the HOMA-IR, and only about 9 had insulin resistance. We did look at differentiation between the tropical versus alcoholic, but none of the data was significant between the two. And we looked at how many had actually a metabolic bone disease based on their DEXA parameters and osteomalacia. Almost 37 had metabolic bone disease, and the last one was what was the difference between people who developed diabetes, who did not develop diabetes. To our surprise, actually, the visceral adipose tissue was more in patients who developed diabetes rather than who did not develop. So as I said, some of these studies which are coming up saying that it is not only the pancreas or pancreatic dysfunction which can lead to, but there are other factors also which will contribute to the dysfunction. Now, what are the management issues? This is where possibly the easiest of all. Maybe metformin, as I said, a very minuscule percentage of it may benefit with it, more so in a maybe acute pancreatitis or immediate phase where the insulin resistance is a bit key factor. You have some studies which said that it does lower mortality. Insulin remains the cornerstone, there is no doubt about it, because pancreatitis or DEP per se increases the carcinoma risk. Use of insulin is predominantly for the hyperglycemia prevention, but not many studies have shown any survival benefit, unlike type 2 studies. The recent additions of the DPP4s and the gliflozins are preferable not to be used. Obviously, incretin modulators you don't use in somebody with pancreatitis, but even SGLT2 inhibitors, because of their actions, because of their catabolic issues and weight loss properties, are generally not preferred in these subset of patients. And the other important thing here, what you require is a pancreatic enzyme replacement to tackle the exocrine dysfunction. The converse of what I have said till now is basically the exocrine insufficiency in diabetes. I'm not touching on that, but there is a whole host of data even on that spectrum. So to conclude, the diabetes of the exocrine pancreas is a common entity and often missed in clinical practice because we don't look for it actually. Diagnostic terminology is improving, and there are unique risk factors who develops diabetes, especially after pancreatitis. And beware of the FCPD as long as we practice in India. And complications are higher, including the mortality, definitely. Insulin is the cornerstone of the management, and pancreatic enzyme supplements help in retarding the progression. I have finished here.